My name is Badrinath Rao. Outperform is bringing you the first of the three series on foot and foot-related issues, especially for runners. We are also open for people who are in sports which require running also. Today's talk is about flat feet, and we will discuss the mechanics of flat feet, what it looks like, what it does. Dr. Srinan will look at the clinical aspects of it, how to test it, what to do with it. And then Abhishek will look at how do we go about training for it to get better mechanics, to get better strength, so that you end up doing the things that you want to do. Go back to running, go back to playing sport, etc. So this picture is a fairly neat picture because the fact that the lady runner, her foot is so neutral when she runs, which is a neutral foot, and that's a direct comparison to how the foot might look if you have flat feet on the guy. The red arrow comes and shows the foot tends to fall inwards. Today I'll be looking at the anatomy of the foot on a very broad scale and tell you how the flat foot really looks like. What are its kinetic changes that it makes up into the body, all the way from foot, all the way up to the neck and jaw. And very briefly, I'll touch upon what really happens in a very popular movement such as squat. And Avi will take over and discuss more in detail. So the Fred Flintstone example is a good example to understand. A lot of people who have flat feet tend to have difficulty stopping. They have a difficulty in starting out as well. So the essence of the joke is really about, when we have flat feet and we are trying to stop or even to start, our foot takes on a lot of work that is not. So that is actually injurious to the rest of the body. The picture representation of the anatomy of the foot is not so important. I'm not going to dwell into every nook and detail of it. What is important to understand is it's a complex joint. It's a complex system, which is made up of 33 joints, which articulate, glide, slide, bend, flex, extend in different angles, in different proportions, at different times. So foot as a understanding is the definition of foot is basically a structure that touches the ground. But it's slightly more than that. It acts as a platform, really, upon which your whole body moves. And it's a platform that allows for your center of gravity, your center of mass to articulate over. So it needs to be a stable platform, therefore. It needs to be a platform which allows for that displacement of center of gravity and center of mass to happen effectively and efficiently. The foot also has another function, which is what we call as the hepatic function. The hepatic function is a function where the foot tends to feel what it is on, be it a tar surface, a grassy surface, a marble surface, within a shoe, a tight-fitting shoe, a loose-fitting shoe, the type of socks, whether it is a cotton socks or a nylon socks, the shape, the contour of the surface itself. So it begins to sense where it is so that your brain begins to recognize how to respond to that situation. So it plays a hepatic sensation. The other role a foot plays is that it is a platform through which you can displace or spread your body weight on it, and also take the force that comes from the ground up into the foot and into the spine. It tends to dissipate, and so it acts as a absorber, a shock absorber, a force, both a force provider as well as a shock absorber. There are three types of foot. If you look at the picture on the right, you will begin to see that there is a normal arch, which tends to keep the alignment of the body fairly stable and neutral. Then there is the pronated or the flat feet arch, or the low arch as they call it here, which really alters the alignment of the body as well. And that is what we will discuss today. The supinated foot, which is our next talk on, is a foot that is on the extreme right, where there is a high arch to it. And it also alters the body alignment, albeit differently. The broad picture I want to give you here is 20% of the world population is flat-footed. And underneath it, there is a very neat picture which captures what flat feet is about. And that is how it looks when you make an imprint, which Srinand will talk about when he talks about how to test, he will look at that aspect of it. 85% of people who have foot issues or who have lower limb issues tend to come with poor footwear. Either it's too small, too big, not properly bought for their foot, etc. 60% of those have direct causative relation to improper footwear, lower limb injuries because of improper footwear. The picture here is a interesting depiction of what a flat feet looks like compared to a normal arch. You can see that the picture on the bottom right hand corner is a fairly interesting picture in the sense that it shows you that the foot has collapsed towards the ground, the ankle has collapsed inwards. There is no space between the ground and the arch of the foot. The picture above it, which shows pronation and neutrality of the foot, tells you where the alignment is going wrong. And the next picture will kind of give you a broader picture as to where that foot is going wrong. This is although the picture is a bit hazy, this is an interesting picture to show you what really happens. With flat feet, your navicular, which is the blue line, tends to drop inwards, which causes the ankle seems to drop inwards. That, as a relation, as a response to that drop, the big toe tends to drop inwards. So the black arrow mark is trying to show you that it tends to go inwards, what is also called as the hallux valgus. Because of that, the fifth metatarsal, which is the pink line, tends to not have a good bearing on the ground. That means it is not planted on the ground well enough. Only the big toe tends to be planted on the ground, which therefore allows for the red line, which looks at how the tibia tends to rotate inwards. So you can see where an action causes a reaction, causes a reaction, causes a reaction. This is what is called as the cascading effect. The picture on the right here shows you that cascading effect. I'll explain the left picture in a minute. When the ankle drops at the bottom, the tibia tends to rotate inwards. Because the tibia rotates inwards, the femur also rotates inwards, which causes a cascading force. But the rotation itself tends to cause a lot of torsion at the joint. So the tibia tends to rotate inwards. Even though the femur is tending to rotate inwards, the tension here is opposing. So at the knee, there's a torsion effect. Then at the hip also, the hip tends to drop forward. There's a pelvic tilt, which causes a scoliotic lumbar curvature, or a lordotic lumbar curvature, sorry, which then tends to drive up the spinal chain all the way into the neck and therefore the TMJ joint. The picture on the left is what I was explaining to you before, about the toe moving inwards. That is where it tends to move inwards. So this is a very quick picture of the squat itself. When the person squatting on the extreme left-hand corner, he has an arch, and therefore the alignment is good. And on the right side of that same picture, the arch collapses, and therefore the femur takes on a different angle and begins to rotate inwards as he squats. A very extreme example, and only for example's sake, is the good and the bad squatting posture that I have shown here, where the knee tends to collapse. And this, now I would like Srinam to take over and explain to you what are the clinical symptoms that people come with and what are the next courses of steps to do.
Hey, Bats, thank you so much for that, for the input into the anatomy and how the mechanics actually work. So once people know about that, only can they understand the clinical implications of what's happening. So moving on, I mean, and as you mentioned, the foot is such a complex structure and it's the platform of the body. It's no surprise that so many injuries related to running actually start with the foot. It's actually a very interesting thing that it starts with the foot. Because it's the first point of contact, and that's the thing. Anyway, moving on to the signs and symptoms. Like Badi was talking about how there's a bit of the cascading effect. As you can see in this image, right from the bunions happening to the foot overpronating and all of that stuff. So basically what happens is when this is the foot, you can see that how the foot is turning inwards and how that changes the whole structure of the body. And the reason why I'm showing you this image is because quite often in clinical practice, what I've seen is people with flat feet don't come with complaints of foot pain. They can come with complaints of hip pain. They can come with complaints of groin pain. They can come with complaints of knee pain. Or they can come with complaints of pain in the lower back, pain in the back of the leg. So the symptoms can vary. It can vary from person to person, depending on multiple factors. Are they overweight, depending on the level of activity, depending on their muscle strength, depending on their thing. So I know the symptoms are varied, but the more common thing is one is what we call as tibial posterior tendinopathy, or back of the heel or back of the leg pain. And then the second thing is a lot of pain on the plantar fascia. It's also called you might have heard of it as plantar fasciitis. Then there's something called as medial tibial stress syndrome, which is also called as the shin splints, which all of you are familiar with. Runner's knee, Achilles tendinopathy, and basically on a broader sense, you can link anything. The issues can go all the way till the neck, and so that's with the signs and symptoms. Because you have to have a broad approach when people come with any runner, anybody comes in with a complaint of back pain. You have to think from the foot till the neck. All right. Before we go into the diagnosis of flat foot, there's something called as a flexible flat foot and there's something called as a rigid flat foot. So in the foot, there is the hard structure is the bone, and the soft structure are your muscles and the ligaments and the tendons. Now, a flexible flat foot happens when there's an issue with the muscles, ligaments, and tendons. It's just actually a normal variant of the normal foot. A rigid flat foot happens when there's an issue with the bones. It can be either due to osteoarthritis or unusual fusing of the bones or a fracture of the bone. All this can cause rigid flat. How do you differentiate whether you have a flexible flat foot or a rigid flat foot? There's something called as the tiptoe test. In fact, as you guys are sitting, what you can do, if any of you are flat-footed and you want to try it out, just lift your heel off the ground. And if you lift your heel off the ground and put all the pressure on your toe, if you can see an arch forming on your toe, then that's what we call that's a flexible flat foot. If you don't see an arch forming, that's a rigid flat foot, and the management is completely different over there. Both can be congenital or they can be acquired. By congenital, I mean it can be there from birth, or they can be acquired over a period of time. How do we diagnose this? I've listed out the diagnosis here. I'll just show you I'll run through a series of images showing you what each test is, so that's easier for you to visualize the whole thing. We start with a wet footprint test. You might be familiar with this image from what Badri showed. And as you can see, there are various degrees of, like you can see on the leftmost thing, you can see the neutral foot. And then you can see there are various degrees of uh, arches or various degrees of flat foot. We'll not go into the details of it. The reason why I highlighted this is there are variations because not all flat feet are managed the same. It has to be individually assessed. You can't just because some particular arch is very common. The reason why I highlight upon this is because especially when it comes to orthotics or foot support and all of it, I've very often seen that people, just because one person is using a particular arch which is custom made for him, his friend who also has a flat foot but might be of a different degree, he also ends up buying the same arch, but then he ends up injuring himself more because the arch wasn't customized for him. So that's very important that you get the degree of your flat foot assist. Really, really important. This is a wet footprint test. Very simple. How do we make that? You just step onto water and then you can step onto the floor, or another way is you can put your leg onto a stamp pad if you find such a big stamp pad, and then put it on a piece of paper, and that will give us an imprint of your foot. That's a wet footprint test. The next thing is a shoe inspection. Usually because flat feet causes overpronation, usually people tend to see worn out shoes on the inner part of your shoe, which is true because there's a lot of overpronation. The pressure seems to be coming on the inner part of the shoe. But like as Badri mentioned in his previous thing, the little foot or the pinky toe is lifted off the ground, and that tends to wear out the shoe. And this image I've shown you is actually my shoe itself. I have flat feet and I run with flat feet. And my shoes usually wear out over here because I absolutely have very little control over the pinky toe, and the pinky toe keeps rubbing into the shoe, and that's how my shoe wears out. And even though the sole is fairly decent, I have to replace my shoes because of this thing. The next test, the too many toes test, is basically you on the left you have a slightly pronated foot. On the right you have a heavily pronated foot. Typically, when someone sees your feet from behind, they shouldn't see more than one foot. They should, more than one toe. As you can see in the right foot, you can see almost 3 toes, and the left foot you can see 2 toes. So typically, if your foot is in a neutral position, you'll see only the pinky toe. That's it. The next thing is the foot posture index. Foot posture index is it's an observational tool used by a lot of physiotherapists and analysis to figure out what is happening. Like you can see the 3 different angles over here. It's an objective list. So you have a list where you need to tick off items and take a photo for basically trying to measure your standing posture from 3 different angles. The details of it is out of this today's presentation. So this is just to get an idea about it. Foot posture index. And the other thing is all these tests that I told you about were standing assessments. There's also something called as a dynamic a single leg task, because so many times when people have a fair, like a first degree arch or something, or a milder flat foot, what happens is when you're standing in one position, you might not get the extent of the arch. So usually what happens, the person who's assessing you, they usually ask you to do single leg tasks like a single leg squat, single leg hopping, single leg deadlift, whatever. There are multiple single leg tasks out there. And then to see the variation and record the video and try to see what is happening. So they do single leg tasks over there to make sure to assess to what degree you go down. Coming on to the treatment, again, now flat foot injuries, all those list of issues we mentioned, right from the foot to the neck, they can either present suddenly or they can present in they can present over a period of time. In case they present suddenly, the treatment is what we call as a police protocol: protection, optimal loading, icing, compression, elevation. Protection simple. You don't load that joint, rest it, keep it away from further activity. Optimal loading is pretty easy. You just how much is required under guided under supervision. You learn how much to load your foot. Icing, everybody knows. Compression, use a crepe band-aid or a multiple supports out there. You can use any of that. And elevation. Elevation is to minimize the swelling or whichever part is affected. If it's the foot which is affected, you make sure the foot is above the rest of the body. If it's the knee which is affected, you make sure the knee is above at least at waist level or higher. Giving you examples. Anti-inflammatory medications like painkiller on a case-to-case basis, and avoid the harm factors like applying heat, very common mistake, consuming alcohol, running immediately. A lot of people, what happens when they develop pain, they rest for one day, they feel they're good, they think they're good, and they go run the next day. And that's the thing. And the fourth one is massage. Massage has to be prescribed. It has to be done therapeutically. A lot of people make this mistake of applying directly going and massaging that place, thinking that's going to help you. And this is the acute, immediate management. And then there's a long-term management, which Abhishek is going to go into detail over here about, or he'll touch upon supports, orthotics, dynamic foot posture exercises, restoring muscle control, corrective biomechanics, and there are various physiotherapy modalities like like dry needling or super soft tissue massage and foam rolling, and there are multiple. There are an endless list of things. So this is it from my side. I'll be happy to take your questions. Please type it out in the chat window. And now I'll be passing on the thing to Abhishek. He'll take it further from here. Over to you, Abhi.
I think we've heard Badri and Dr. Srinan speak about the management of it, and Badri was speaking about how biomechanically this is biomechanics gets influence from right away from the foot all the way to the neck. I'm going to be speaking about how we could look at correctives that you can do probably from orthotics perspective. What happens when you use an orthotics, which is one of the most or widely used method to help with flat feet. But from my experience, and also for someone who I didn't have flat feet, but also developed some amount of a fallen navicular, a fallen arch because of an overload when I was playing professional cricket, and that's when I got into understanding the foot a little bit better, and a lot of shin splints that turned up during that period was generally corrected by orthotics, but people just asked me to wear orthotics and I started bowling. It was a 50-50 choice that happened at that point, and my body adapted, so it took in well. But that's a really, really shitty odds to work with if you have to look at how we can help integrate the insole into someone's feet. It actually takes about 9 weeks for that adaptation to happen. So, and as she was saying, we have so many people walking here and saying, "Oh, yeah, I just bought this off the shelf." The insoles need to be made as custom as possible because everybody's foot length, that is the length of the foot, is different. Everybody's position of the navicular, which is the bone at the arch, which needs to be supported by the insole, is different. So we need to kind of look at how we can make a custom insole that can do that. But also, that's just probably 10% of the job. The main aspect is understanding how you can load this foot, help it understand new joint position, because all this while it has been working in a position which was, like they showed you many times, it was pronated completely, and there were so many changes. So that means also there were so many muscles within the foot musculature and the lower limb, which is the calf and the post-tib and anterior tibialis region, which has been under or rather has been dormant all this while. So getting activation of these aspects all of a sudden could cause new issues which might show up as knee pain or pain under the foot, several areas. And a lot of them, that's why they buy it, they try using it, it doesn't work, they take it off, they have a lot more pain than before. But the whole process generally takes, a break-in process generally takes about 9 weeks, which I've observed. There are several times we kind of cut corners, but that's generally because we've seen foot adaptation and neuromuscular control of the foot improving in that short period of time, and hence we move them faster. But if you had to do it yourself, you would have to go from walk for a couple of hours to integrating it into a whole day affair. Then you start doing low intensity activity with it, and then you do you start doing strength work, which should be ideal, but then the strength work had to be part of your finished. So I'm just going to briefly touch upon those aspects now. And just quickly run by, because one of the things that Badri was talking about is those restrictions, and if something that you guys could do back home is looking at the first picture here, where you can see the entire fascial chain that there is, and this fascial chain is the reason for this is actually the superficial posterior line, but you can see how all of these areas that they were talking about, where if there was internal rotation at the foot, will become compensated right all the way till the neck. So this chain is what requires myofascial intervention, either through a physiotherapist or by the means of a foam roller or anything of that sort, so that we can that you can mobilize. But these are the compensated areas that your body will pick up, and that's why you will start seeing a lot of the runners having a shift in the head position, also have a lot of rotation happening, unusual rotation happening at the thoracic rib, because most of the running mechanics initiate with the lat on one side and the internal oblique on the other side and the hip on the other side. So this, if you can see the first image here, you can understand how this cross pattern happens and how it is important to kind of address these restrictions before you can actually do exercise, because if you don't, then the loading becomes off. The loading is loading changes, and if you're trying to, with these restrictions, try to do rehab exercises, you just see it being compensated all the time, because this pattern which the body's picked up just continues, or if there's again a 50-50 chance that your body learns it in a different way and adapts, wonderful. But it's that is a scientific way of going about the same thing as well. I remember a friend of mine who used to make insoles for me, who is from Australia, and he used to play cricket with me, and he was until date probably the only guy who's made the best insole for me. But there is so much more technicality from an insole, because we need to look at how the forefoot behaves in respect to the rear foot, or the rear foot behaves in respect to the forefoot. Also looking at how the biomechanics of the insole can help and assist the current foot mechanics as well. And he had actually made a insole for me for running in and bowling, and he had made an insole for me when I was standing in and fielding, because the foot mechanics changed sprinting versus the 80% running speed that I was running in my. So you can actually go down to that amount of detail. But I've yet to meet people. There were a few people who came in and went out who had great products who could do this, but either they had logistical issues to deliver it because they were doing it from another country. But I think more there are people who can make the insole, but what's not happening is the integration of the rehabilitation plan or integration of the break-in plan has not been efficient. So there has to be my suggestion is to figure out someone who could at least speak the same language in terms of looking at rear foot to forefoot mechanics, also addressing how your running mechanics actually is in gait, in when you're running in your current activity. Maybe look at it, if you're a long distance runner, look at videoing at different points in the distance as well, maybe one at 10 kilometers, and one at 20, one at 30. So you could probably make different assessments to see what is failing, and then make a plan. If they look at all these aspects, and also help you with a break-in plan that is consistently being retested for to look at adaptation. And sometimes what happens is the insoles have too high an arc just because you need to make the corrections. And if it had a too high an arc, you will see that the adaptations may not go your way, even though you're doing the right things. So at that point, you might need to look at reducing the arc so that the foot learns different stages. So I've seen many a time we had put in someone with a standard 2-degree arch, but his foot was so flat, and like you were mentioning, rigid foot. So the adaptations for him to happen was actually just the tissues around the navicular were getting smashed all the time. So he did not want to use it. So looking at people who will address these many things into a program is something that you might need to look at, or probably look at an insole, get an insole made, and then work with a physical therapist or a strength and conditioning guy to kind of make the program for you, and look at how definitely while making the insole, look at how a biomechanist can give you input on what is really required for your running mechanics, and that's something because it's a custom insole in the first place, right?
Right. So what you're saying is that just because he got an insole made at the start, that can change. It's not a static thing.
Yeah.
It is a dynamic thing, right? That's his takeaway, at least.
But my stance on insoles in general has been is a great tool to take away pain and help learn better mechanics. But what I do with a lot of our athletes is to kind of consistently make sure that their foot is still learning to function better and
Got
not be
it.
dependent on the insole. So
Right.
that maybe in about, it takes a long time, maybe about
It is.
5 years, 6 years in, if the foot begins to behave, we can slowly wean them off the insole if required.
Yeah.
But generally, if you're playing professional sport and it is a sport that is very heavily dependent on footwear, like fast bowling or football, my suggestion is to have the insole, simply because what is the biggest factor when you change shoes is the surface that your foot connects the ground changes
Okay.
every single time you wear a new shoe, and so you have new issues that turn up. But if you have an insole, the surface never changes. But it needs to be looked out maybe every 6 months to a year to see if there is any wear and tear at the insole, which is again going to cause different changes in the biomechanics as well.
Got it. No, I mean, yeah, coming back to your point of getting that whole intrinsic muscle control of the foot, I think that was what you were like, so that people learn how to. I mean, I know because having flat feet myself, I know how hard it is to develop that control every single time, because I used to lift weights with shoes before. And then in order to learn bracing with my feet and all of it, I started lifting weights barefooted so that I learn how to brace it. And every single time I need to remind myself, brace your foot, brace your foot. Otherwise, it just doesn't come naturally because you're.
That you utilized any sand-based surface to better your intrinsic patterns in your foot? Did you try that anytime?
Say that again. Sorry, I missed that question.
You use a sand-like surface, like a beach or anything like that, to better your foot mechanics?
I've been using a towel just to work on the towel and stuff like that. I haven't.
Because I lose that when I work with football clubs. I've generally had them do some part of the preseason at the beach.
Okay.
And I've actually done a lot of foot-related work for them on the beach, so that it can integrate well. Because when you're stuck with the football shoe, which is really narrow and it needs to fit really tight. A lot of India have a misconception that wearing smaller shoes it creates a better brace, and it just screws up the whole foot mechanics completely.
Right. So a bad question for you. If so, we were talking about all the how your running pattern should be great and all of that. So a lot of questions a couple of runners might have is, do you think correcting all these arches and correcting this thing will make them a faster runner, or is it more about optimizing their running and making it a better thing? What's your take on that? Why would
running?
Like, see, now, for example, a runner might come up to you and say, I've been running. I do long distance, slow long distance, but for the last 10 years, I might have not experienced any pain or anything like that. So what would be the reason why? Are we telling him that, hey, this can optimize your running, or is it more to make sure you run injury free, or is it make you a faster runner? What would you say on that?
Any and all biomechanical changes don't necessarily look at speed or distance or anything like that.
Okay.
If you're training a javelin thrower, you're not looking to increase his distance as much as you're looking to increase the efficiency of throw.
Okay.
Which ultimately might increase distance.
Okay.
Because your entire power generation becomes more sequential, more optimized.
Okay.
Similarly, for a runner, a long distance runner, putting on an insole is not going to guarantee better speed.
Okay.
Or doing strength might not guarantee better speed. But doing biomechanical changes, add strength work, to that add conditioning work.
Okay.
You certainly become a more efficient runner. That is, you're able to break less on your stride.
Okay.
You're able to maximize or optimize stride length. You're able to minimize the ground contact time.
Okay.
Which therefore adds a few of a millisecond to your running speed. But if you add those milliseconds every step, it might end up becoming, I've taken less time.
Got it.
But less time at the cost of mechanical inefficiency is injury. less time because of mechanical efficiency is uh, is greater speed.
Okay. Got it.
So people shouldn't look at biomechanics to say, okay, if I do these biomechanical changes, I will get better speed.
Yeah, because a lot of biomechanic works involves a lot of intrinsic work, which you can't make, or it makes a subtle difference in their running, which they won't be able to appreciate outwardly. Like, like you go lift weights and all that, you can appreciate the muscle strength, you can see the thing. So, I mean, a lot of people
Yeah.
might ask, I can't even see the improvement. They might not realize it then. It might show a few months later or a year later, but they might not realize it at that point of time. So, that was
That's correct.
right. Abhishek, you wanted to discuss a case or something? You want to do a case study or something? We still have about 10
Have we
minutes.
done questions or?
Yeah, we're done with questions so far. If anything comes in, I'll let you know.
Okay. So what I was what people have asked is one of the as a case study. I think one of the aspects in your case, I think taking just your case as a case study, you had flat feet,
Right.
and maybe you could just take us through different
Yep.
ways you went about handling it. So, and probably me and we could probably look at saying what our thoughts on the same process could have been.
Okay.
Like I said, even I did not have flat feet at any point of time, mainly because I used to do a lot of barefoot running from the time I was a kid. Just
Okay.
loved playing barefoot from the time. So just integrated well. It's an area of concern right now because we see a lot of the young athletes walking in, and it's one of the major causes for it is the whole culture of wearing slippers all the time after a sport or after an activity, and which is really bad for even at home. Yes, even which is really bad for the foot. So that's why we keep telling people get off their shoes at home, and I think the other option which Bads has always been promoting, which has been his Crocs, and has always but then we've seen how just small changes like that can make a big change to the entire gait, right? So because I think we had one of the injuries to a left arm fast bowler, who's played Ranjit, who came in, had issues with it, had worked with NCA, many other places.
Generally, a lot of shin splint issues.
Yeah, sorry.
We had a lot of shin splint issues which had not been dealt with.
Yeah, and not attended to. But the actual change that we had to do is to also look at how Bads did his biomechanics work in the nets. Looked at how he's running in the nets at the point of loading and everything. The whole gamut of things, along with which we looked at what are the root cause issues we saw at the ankle and how we could stabilize it. What were the compensatory patterns at the ankle, and how we could help him integrate better musculature or like the post hip and things, and integrate it well to the hip, and take those factors that were leading to compensation, which was his biomechanics when he was running into bowl. Without that correction, this could have not been the entire gamut of correction would have not happened. So that's something that we had seen. It takes a bit of time normally for mechanics because it's so ingrained and so endurance based. All the tissues and ligaments and getting neuromuscular control off the foot and intrinsic structure of foot takes a little bit of time. Normally, it does take a little bit of time. But if you enable the process optimally and help him integrate stage by stage and keep reassessing at every given point, saying what kind of progress happened, progress and regress movements based on how he's feeling, you'll see a complete integration. So I think if we can pick up, that was a case that me and Bads actually one of our first fast bowlers that we both worked together.
Okay.
And it was after so many people had kind of looked into it, and we kind of helped him reintegrate back to bowling, which was his livelihood. So it makes all the difference to him. I think you can speak about yourself, I guess.
Yeah. I mean, I just like case study. I just have to talk about myself. I don't need anybody in. So for me, it's always been a learning curve because what happened was initially. I mean, mine is congenitally flat feet. I'm from birth. It's always been flat. My arches never developed.
So during mom or dad also having flat feet? Any one of them?
Why? So the funny thing is, mom and dad have. So mom has one flat foot, one arched foot. Dad has one flat foot, one arched foot. I got both flat feet. So it's that is
you got the best.
The best of the best. I'm not complaining because it was really useful during my swimming days because I
Yeah,
had a
yeah.
very flexible ankle, and during my swimming days. So, I
I was
mean,
going to ask you about that
yeah.
actually, because I've
So,
seen quite a lot of swimmers also come in with flat feet, and it was a commonality amongst a lot of swimmers because they
yeah,
don't do too much dry ground training,
right.
and they're in an anti-gravity environment all the time, and so I think,
Yeah,
but as to use the flat foot as a pin, it works really well, you know.
it does. I mean, you might use it to your advantage. So,
Yeah.
so I think so. When I was young, we never really bothered with the flat feet because it wasn't really like you said. It wouldn't show up anywhere, and I never had any foot pain or something. And of course, we used to run a bit, but it was just about 5 kilometers a day or something. It isn't really much
But,
because if you're young and all of it, you don't feel anything. But what I did realize is as I started running marathons and I started crossing those 30-kilometer mileages or the 25, 30-kilometer mileages, the first thing that developed for me was
yeah,
IT band syndrome. It's not like I was someone
yeah,
who wasn't doing weights and stuff. So I was kind of confused because I'm doing all the weights, I'm doing all my thing. But then, like you said, I mean, this has always been a learning curve. So initially, then I realized, okay, it's probably the gluteus medius which is weak, which was a contributing factor, but that wasn't the root cause for the thing. I wasn't thinking of what was the.
mm,
This is all before I started sports
yeah,
medicine. So I wasn't thinking of what was triggering off the glute medius. So I started
yeah.
focusing on glute medius related
Correct, correct.
exercise, and then by the next marathon, there wasn't any IT band friction syndrome. And then what happened was, I figured after that, I started developing pain on the inner part of the sole or inner part of the foot, and that started transmitting to the inner part of the knee. And that's when I started making the connection between the whole glutes to the feet. And of course, by the time I started my sports
But it
medicine
goes
and
in.
stuff, so the awareness was a little thing. Uh, Maybe like you said, what happened was I've always used those commercialized arches. Like you just buy a shoe from
Got it.
a store like an
True.
E6 or a Nike or something. So even when I started observing my running pictures and stuff, where they just take a picture of you towards the end of your race, that's where they get most pictures, where your form is completely off.
Mm.
Surprisingly, my foot was never pronated.
Yeah.
It used to always be on the slightly supinated or almost thing. But then again, I'm attributing this to the arch because
Got
I
it.
don't. But then when when Badri and me started working on my foot, we started seeing the whole peroneus muscle and all the
Yeah.
muscles on the lateral aspect of the foot. I saw how weak it was. It's never been utilized. It's never been utilized. It's just been making use of the support, getting lazy because of the
If you
support.
saw
And
the chain that I put in that image in my presentation, if you see the chain that I did, the
yes,
peroneus goes in all the
yes,
way to the bicep femoris,
yes,
which connects at the hip.
right.
At the
Connection is poor, Abhi.
so and that's why we
Abhi,
need to.
Abhi, you need to repeat what you just said. Connection is poor.
Okay. No, I was saying in the image that I had shown earlier as well,
Yeah,
you can see that the whole the
That's the thing.
chain that is there, which comes from the peroneus, which links into the hamstring, which is the
right,
rectus femoris part, which is generally a chain. A lot of them have flat feet, which has not been addressed. It's not just
right,
the IT band which goes into
right,
anterior tibialis, and this is a whole weave that comes in, and
right.
that's something that
So,
um, and also one of the things that you mentioned was that they had to do glute medius exercises, right?
right.
So, but what tends to happen, some really, really bad foot mechanics and there's a fallen arch, the load on the glute medius to still stabilize the hip
Hmm,
is too much to handle at that point. So without the
right.
correction at the foot, even if you do glute medius exercises, it's not going to,
Yeah, it's not going to.
this
You can't just correct one
uh,
factor. You need to correct the whole cycle. We hope you guys enjoyed the webinar. Hope to catch you all next week.